Okay, so as Ann said, I'm Laura MIchaelis. My job up here was I've been asked to talk a little bit about the medical goals. What should sort of the whole of your health, what other things do you need to worry about, in particular when you have a myeloproliferative neoplasm? And I called this controlling what you can because we all know that you didn't ask to have this disease. You didn't ask to be sitting in this room. And so a lot of times, you don't feel there's much justice. And if there's one lesson from my job, is that there is no justice here. This is all just about sitting down saying, I didn't ask to be here, but what can I change? And that's a little bit about what we'll talk about today. So the first thing I want to talk about is communication, because at least in the US, and my experience has been the biggest place where things break down is the failure of communication. So what you have is you have some information about yourself, you have information about the patient, and theoretically that's supposed to be known by the primary care doctor. You have information about the disease, this rare kind of myeloid disease, and that's supposed to be the purview of the hematologist. And the reason you guys are all here and the reason that we're talking is because you are the bridge. You are the bridge between information about disease and information about you, and the bridge between the communication between the hematologist and the primary care doctor. You've gotten some tips today about why that's important, why it's important to carry a card with you, why when you travel you should carry your latest note and what your CBC is. Maybe you should make sure that you actively ask your primary care doctor to send their notes to your hematologist and vice versa. And that's because you have to act as that advocate in that communication between maybe you have a rheumatologist, maybe you're about to have your knee replaced by an orthopedic surgeon who's never heard of polycythemia vera. That's the kind of job that you have, and that's when that breaks down, problems happen. So today we're going to discuss a little bit about these unique concerns. I want to review medical targets for minimizing infection risks in patients with these diseases, optimizing cardiac and vascular health. Again, this is going to repeat a little bit of what Cicely says. It might come a little bit from the US perspective. I'd like to talk about fertility issues and things that face younger women in particular with this disease, and limiting risks for other cancers. So the first thing is I want to talk a little bit about infectious risks. There are risks that are unique to people with myeloproliferative neoplasms for both bacterial infections, viral infections, and these rare fungal infections. We'll talk then about the risks for heart attacks and uniquely a risk for bleeding. We spent some time today about risks for venous clots and arterial clots, but we haven't talked much about risk of bleeding, which can also happen in patients with essential thrombocythemia in particular. And that speaks to the fact that this is not a disease where your bone marrow is just making too many healthy cells. We know this is a disease where the bone marrow is making cells that are aberrant, that don't understand the signals that are coming from the blood vessels and can't run through the blood vessels normally. You can call them sticky, you can call them misshapen, you can call them whatever you want, but the truth is they just don't interact with your blood vessels normally. And the results are both bleeding and clotting risks. We're also going to talk about things that can happen in your brain as well. So this is just a little cartoon because we like to put cartoons up, and that's because there are things that you can control and things you can't, and nobody can control their age, although I'm working on that, and if I get it, I'll patent it, and we'll see what happens. So infectious risks, these little buggies up here on your upper right side, let's see if I got a pointer here, yeah. So these guys are bacteria, which come in lots of different forms. Lots of different bacteria can be found in our bodies normally and can overgrow in situations where people are immune suppressed. And people can be immune suppressed if you're on drugs that lower your white count, for example. You can be immune suppressed after you've had a transplant, or you can be immune suppressed because the basic normal immune function of your body is being impaired, for example, through disease. These are viruses, and they look a little bit differently and require a different part of your immune system to be controlled. And these, relatively beautiful picture here, this is fungus. And fungus, it's It's, again, one of the normal conditions of the body. We all have some spores that live in us depending on where we're from, but the ability to keep that under control and not let it blossom requires that your immune system work well. So large studies show that there is a slightly increased risk of fatal infections in people with myeloproliferative neoplasms. This is probably biased because towards people that are in the sicker category with myelofibrosis rather than in an early category of disease with, for example, polycythemia vera or ET. And why might that be? Well, the disease itself can cause some irregularities in our immune system. There is splenic dysfunction. We've already heard from one of our colleagues here who's had his spleen out. We know the spleen, while not absolutely essential, certainly does provide a lot of a backdrop for your immune system as well as a way to keep your immune system healthy. There is debility from chronic disease, people that have lost a lot of weight, whose nutritional patterns have slipped, who don't have the strength that they used to. Those people can be more risk for infection. Low white blood cells is called neutropenia. I'm going to describe that in a second. And that can occur with some of the medicines that we use. And treatment with JAK inhibitors can increase people's infectious risks. The JAK inhibitor, of course, ruxolitinib, the one being approved. So neutropenia is determined by looking at one's blood smear and finding out if this particular kind of white blood cell, which is called a neutrophil, is made in adequate numbers, adequate percentage, and that's calculated. Now, many people who are on hydroxyurea have a slight decrease in their neutrophil count, not enough to make it dangerous. But if you're on hydroxyurea and your hydroxyurea dose is a little too high, sometimes your white blood cell count can drop relatively steeply or into a more dangerous risk, meaning under about 1,000 per microliter. People use the phrase or the terminology ANC, absolute neutrophil count. And when that's in the dangerous zone under 1,000, then some people are at higher risk for certain kinds of bacterial infections. Your doctor can tell you that, or you can look on your CBC. If that's the case, sometimes what we'll do then is back off some of that medicine that you're on, or we'll just watch. The treatment, if you're asymptomatic and there's no infections, neutropenia itself isn't dangerous. But if you have persistent infections, then sometimes people are started on prophylactic medications. Prophylactic meaning to try and ward off additional infections. And those prophylaxis are generally called for only in selected patients. You'll see this quote up here, the NCCN. This is sort of the standard in the United States that we look to for guidance of what's the, quote, standard of care. And in patients who've had repeated infections, either because of treatment or because of neutropenia related to their spleen size or something else, then we generally recommend some prophylactic antibiotics. These can include a class of drugs called fluoroquinolones. In the viral category, acyclovir. And in the fungal category, a group of drugs that are known as the azoles, for example, fluconazole, posaconazole, or voriconazole. I want to repeat what you've heard from Ken also about the importance of vaccination. Vaccination should be done everyone needs a flu vaccine, for example, and your family needs a flu vaccine. Countless patients will tell me, I don't like the flu vaccine, I get the flu. That's not the case. The flu is not a subtle thing. If you've ever had the flu, it's absolutely awful. And unfortunately, in our patient population, the flu can be fatal. So the flu vaccine is a necessity. If you're immunocompromised, meaning if you don't have a spleen, if you've had splenic dysfunction because your spleen has clotted or there's been you've had some event to it, or if you're on a JAK inhibitor, which we think does immunocompromise, you want to avoid the type of vaccinations that include live viruses. So some vaccinations, in particular the zoster vaccination, has a little bit of live virus in it. And we don't recommend those in people who are at baseline immunocompromised. I understand and I don't know the case, maybe Cecily you can tell me here, maybe I understand there's a new zoster vaccine that doesn't have live virus. great. So then we've got a blanket statement here. We don't recommend, if you've got this disease, for you to get the zoster vaccination. Now, that doesn't mean your loved ones shouldn't get it, and if your loved ones are healthy, keeping them from getting shingles is a good idea. And then if people have had that, however, if your loved ones have had a live virus vaccine, you want to avoid contact with family members for about 7 days because it can be shed. That's also some of the childhood vaccinations are live virus, so that might be a time when you didn't bathe your grandchild or something like that because, again, those live viruses can be shed for a short period of time after that person is inoculated. So there is on the ruxolitinib trials, they did have a slight increase in infections in the people on Jakafi, bacterial infections or the respiratory or the urogenital tract. The frequency of these infections decreases with the length of time that you're on the therapy, but severe infections, the kind you needed to be hospitalized, were no more common among those on Jakafi or ruxolitinib as those on placebo for the COMFORT studies. But there is an increased risk for relatively rare infections, for example, tuberculosis reactivation and unfortunately shingles or herpes zoster are more likely to occur on ruxolitinib. And so for that reason, if you've been in an area where you might have been exposed to tuberculosis or you have the possibility of dormant tuberculosis, mentioning that to your physician before you go on ruxolitinib is a good idea. It can be tested for, and I've had one patient reactivate tuberculosis on ruxolitinib, and it is exceedingly difficult to manage both bad myelofibrosis and active tuberculosis at the same time. This is just looks a little bit at the infectious risks, and what you'll see here, this top line, so just to go over what this graph is, the higher you are up here is the more the incidence, the likelihood that this has happened, and this is time. And this looks at infectious complications according to whether or not people have a high disease severity and a big spleen. And this just shows that the likelihood is highest with people whose disease is a higher burden and whose spleen is bigger. So the sicker you are, again, the more debility you have, the more likely infections are to happen. So here's some short recommendations and tips. Avoid starting therapy if you're actively infected. So if you actually have a bad cellulitis or you've recently come over a pneumonia, that's not the time to start the therapy. Let yourself heal a little bit to the best that you can and start the therapy when that infection is not a problem anymore. Ensure no tuberculosis. Watch for signs and symptoms of zoster. Rule out hepatitis, for example, hepatitis B, before starting therapy. There is no need for you routinely to take prophylactic antibiotics, but you do want to make sure you take into account common sense measures like hand washing, not going to work when you're ill, things like that. And if you do have repeated infections, then speak to your hematologist about maybe it is time to start some prophylactic antibiotics. So the next thing I want to talk about is optimizing cardiac and vascular health. So we've talked and you've heard all day about blood clots. I just want to emphasize there's two kinds of blood clots that we discuss here. One is arterial blood clots and one are venous blood clots. Arterial blood clots are clots that happen in the vessels that lead oxygen-rich blood out of the heart and lung system to the rest of the body. So your aorta is your largest artery, and that's what takes blood up north to the brain, for example. And when that is impaired, you can have blood clots to the brain, which are strokes. Two kinds of strokes. You can have the kind of stroke where the oxygen-rich blood is blocked from being delivered to the brain, so a traffic jam, and so a section of the brain doesn't get the oxygen-rich blood. Or you can have a bleeding stroke, where there's some interruption in the blood vessel, and the blood vessel ruptures, and blood doesn't get distal past that bleeding site because there's been a traffic accident. So traffic jam versus traffic accident, but both leave some parts of your brain without adequate oxygen. The other kind of major arterial event is a heart attack. A heart attack is where the oxygen-rich blood doesn't get to the key blood vessels that actually supply oxygen to the heart muscle. So these are the common and the most dangerous of the arterial clotting events. And they're more common in people with myeloproliferative neoplasms. And unfortunately, just because of other competing problems, we see that their most sort of danger, the most common kind of mortality in younger individuals with MPNs comes from these cardiovascular events, and that's why, and strokes. So that's why when we're up here talking about ways to prevent these, that's sort of where our level of urgency as providers comes from. We know that they do happen both at diagnosis and at follow-up in patients with ET, PV, and myelofibrosis. And why are they more common? Well, they're more common because of genetic differences in the way the blood cells are made, because of the elevation in white blood cells that probably makes for more inflammation when small vascular events happen, and because of the viscosity of just having too many cells. So this abnormal interaction between the blood vessels and the blood makes for this situation where the this normal viscosity, the normal choreography of the blood traveling through the blood vessels is aberrant. So again, you've seen this. Cardiac risk factors include things like your age, smoking, total cholesterol, your good cholesterol, diabetes, blood pressure, your activity level, and your weight. There are calculators online, and you can use those calculators and plug in these numbers for yourself. And through that, you can sort of get your risk. So I just looked at this gentleman here, a patient of mine, 60 years old, no diabetes, smoker. Total cholesterol was 210 with a good cholesterol of 30, that's a little bit low, and a blood pressure of 140/70. Now this calculator doesn't include something like a myeloproliferative neoplasm, which we know increases your risk overall. But when I was talking to this patient, we just pulled up the calculator and we went through his numbers, and he has a risk of a heart attack in the next 10 years of about 23%, which is not nothing, right? And we think, well, he's also got polycythemia vera, that we're doing our best to control it. He's on aspirin, he's on hydroxyurea, but that raises his risk anymore. So what is he in control of? Well, if he's not a smoker, if he takes medication or diets to reduce his cholesterol by 30 points, if he lowers his blood pressure, his risk drops to 13%. Now, I can't eradicate his myeloproliferative neoplasm. I can control it, but look at the stuff he is in control of. And this was very illuminating for him to sit there with his calculator and go through the stuff that he's in. So I would really encourage you. This is what it looks like. It's called the Heart Risk Calculator. You can find it at the American Heart Association. Plug in your numbers, and that will give you guys an ability to really see what's out there. And again, it doesn't include your myeloproliferative, but it does allow you to go specifically and really see for yourself what it means when you lower your cholesterol level, when you lower your blood pressure. So about controlling hypertension, again, this is something that Cicely talked about. There's various ways to do that. I want you to think about many of you may be on hypertensive medicines. They work in different ways. So when you go to your doctor and you're looking at your targets, am I meeting it? Sometimes it's helpful to think a little bit about why these work and whether or not there's a different strategy to control your hypertension that may be helpful. What are your goals for your blood pressure? Well, you want to be in the green zone, like always. We want to have your systolic, the first number, less than 120, and your diastolic, the second number, less than about 80. That's ideal. These other numbers, certainly if you're in these sort of yellow to red categories, that is certainly going to amplify the risk that this blood condition already gives you for strokes and heart attacks. So what are our targets here? Complete abstinence from smoking, heart-healthy eating patterns. You want to use the calories you take in, and you want to choose some high-nutrient foods. That food pyramid that we have really emphasizes fruits and vegetables, whole grains, low-fat dairy, etc. And you want to keep your body mass index between 18 and 24.9, which, what does that mean? Well, This is another calculator you can find online through the American Heart Association, where you can find out what's your body mass calculator, or you can do what I do and you can look in the mirror and say, I'm unfortunately veering a little bit in here where I want to get back into here. But this just goes to show you a little bit about that your body can give you some idea of where you stand. And there is no reason people need to be sort of model thin. But you do need to be sensible, and moving your body mass index closer toward the normal zone is not only going to help reduce your risk of strokes and heart attacks, it's also going to help reduce your risks of needing a knee replacement. And as we've heard over and over today, diet and exercise, which are the ways you get your body mass index, are good for other things than just your cosmetic appearance. They're particularly good for depression and fatigue. So about your cholesterol, again, I'm not going to spend too much time on this. You'll get this in the slides, and Cecily did an incredible job talking about this. But this just talks a little bit about how we measure cholesterol, what's the good and the bad cholesterol, what your targets are, and some kind of interventions that you can do to keep that cholesterol under control. Exercise, again, it's been emphasized. There's unbelievable benefits to it, not only in weight loss and maintenance, in endurance, in your heart rate and how you feel, in stress relief and improved sleep. You know, this is the goal, 30 minutes, 5 to 7. Doesn't have to be, lifting weights in the gym. It can be gardening, it can be dancing, it can be parking ways away from your distance so that you walk there instead of driving there. You can walk your dog. Any of those things are little things to just get up to 30 minutes a day, keeping your heart rate up. So what about venous clots? So these are the ones not where oxygen-rich blood from the heart lungs are getting impaired, but it's where there's blood that's distal in your body, distal in your legs, or maybe distal in your arms, not as commonly, and when it's trying to come back to the heart and lungs, it encounters a roadblock. And sometimes this is in the legs, which is what we call a deep venous thrombosis, or DVT. Sometimes it's in the lungs, which is called a pulmonary embolism and quite dangerous. Rarely, but sometimes these deep venous thromboses can move and get into the lungs, causing the pulmonary embolism. And they can also occur in the blood vessels of the stomach and the middle abdomen, which we call splanchnic vein thrombosis or portal vein thrombosis, for example. And they can happen in the blood vessels that drain the brain, called sinus venous thrombosis or cerebral venous thrombosis. All of these also happen. In particular, things like these sinus venous thrombosis, the blood clots that occur in the vein, are more common in younger women or people on oral contraceptives and can be quite dangerous. So these also are where your hematologist needs to know. There's been, unfortunately, several cases where I've been treating somebody for an MPN and they've had a blood clot and their primary care doctor dealt with it and I didn't know about it. This is an important place where people need to be in communication, because any blood clot that people have with this underlying disease means the disease needs better control if possible. This is the trigger point to starting cytoreductive therapy like hydroxyurea or something more than phlebotomy, for example. Or if this occurs on treatment, means you need to sit down with your hematologist and say, is my disease well enough controlled? Do I need to change therapy? Now, prophylactic therapy for blood clots, meaning I haven't had a clot, do I need something, is sometimes necessary around the time before or after surgeries. And that's because surgeries like knee replacements, shoulder scar, any kind of, for example, abdominal surgeries give you an increased risk of clots afterwards. So your surgeon and your hematologist need to be in communication, because sometimes additional blood thinning is needed before or after surgery. Once you've had a blood clot, blood thinning agents need to be applied, and I think the duration of time that people are on blood thinners like Coumadin, for example, or enoxaparin, really depends on the size of the clot, and it depends on a conversation with your hematologist. There are many of my patients who are on blood thinners indefinitely once they've had a clot. You also want to make sure that you determine whether or not your aspirin should continue or not. And again, there's no hard and fast rules about blood thinners, whether or not you use them with or without aspirin in addition. So this is, again, a conversation. And finally, extended treatment. How long should I be on warfarin? How long should I be on it? Depends on the clots, whether or not this is your first or second, etc. All right, so I turned this off by accident because I got nervous because Ann told me I have 5 minutes remaining, so I'm going to talk faster. All right, what about bleeding? But, except I'm the last person, so really, what are you going to do? Bleeding. So bleeding can occur in patients with very high platelet counts. Generally, it's mucocutaneous bleeding, nosebleeds, hemorrhoids, bleeding of the gums, but it can be in the GI tract. One of the things this is caused by is a condition called acquired von Willebrand's disease. The way I visualize this with patients is normally your blood vessels have just the right number of platelets and proteins to allow them to coordinate in the way that blood clots. But when you have too many platelets, it turns out that they glom onto all these blood clotting proteins. This stuff is in your serum and your plasma that usually helps you clot. Too many platelets means that those blood clotting proteins can't interact with the blood vessel wall normally. Again, we get back to the fact that the choreography is all off. They just can't speak to one another. So acquired von Willebrand's disease does give you a risk of bleeding if you're somebody with very high platelets, meaning above 1 million, 1,200,000, 1,300,000. In those situations, if you've had nosebleeds or gum bleeding, you have to talk to your hematologist about that. That's a reason to start treatment. Modifying surgical risk, we discussed a little bit about this as an important part of conversations between your doctor and your hematologist. I want to briefly talk about fertility. 37-year-old woman, a patient of mine, had a calf thrombosis while on birth control. She got appropriately worked up and was found, because she had this slightly elevated platelet count, they looked for a JAK2 mutation, and she was referred to me because she was JAK2 positive. She had a platelet count of about 603,000, 604,000, and her questions to me was, did the birth control cause the blood clot, or did ET cause the blood clot? Can she take it again, and can she try and get pregnant? And those are very difficult questions. They're probably worth more than I have in the 5 minutes left, but we'll briefly touch on them. So Cicely has talked about the fact that hormonal contraception plus essential thrombocythemia gives you a hypercoagulable state, and that hypercoagulable state might just give you a lower extremity blood clot, but worse than that, it could give you a cerebral clot, it could give you a clot in your stomach lining or in the vessels that drain the stomach, or a pulmonary embolism. So that hypercoagulable state is a dangerous one, and we try and avoid it. And that's why we try and avoid hormonal contraception in individuals, women with ET or polycythemia vera. Turns out that pregnancy, even if you don't have a myeloproliferative neoplasm, is also a hypercoagulable state, which means that when individuals with these diseases desire to get pregnant, it requires a lot of coordination and a lot of forethought. And it can be done, but it needs to be done carefully. Thrombosis, unfortunately, is the #1 cause of maternal death. And partially that's because we're good at other things, but it is difficult. So contraception. Combination hormones are more dangerous than progesterone-only hormones, but in general, we recommend barrier protection or non-hormonal contraception for individuals with for women with myeloproliferative neoplasms. There is an increased risk of blood clots on people with ET and who take oral contraception. This is not a prospective study, but a case control study, and you see almost 0.25% of people in this study that had ET and were on oral contraceptions with a venous thromboembolism. Pregnancy, this is basically the placenta here is just one big set of blood vessels. And so you can imagine that if you have a blood clotting disorder or a disorder where your blood doesn't interact with the blood vessels very well, both on the arterial side and the venous side, it is very hard for that placenta to form normally and for the interaction between the blood system of the fetus and the blood system of the mother to stay patent. So pregnancy outcomes are impacted by having one of these. The live birth rate of young women with myeloproliferative neoplasms is less than that of is lower than that of people without myeloproliferative neoplasms. First trimester losses can be between 10 to 20%, and late pregnancy losses can be very high in the range of 10%. This is likely because of placental abruption to some extent and intrauterine growth. So we do not have the data to know if we could, what is the exact best sort of way to change those interventions. We do know that preconception counseling with risk assessments with yourself and a high-risk hematologist is incredibly important. Claire Harrison has written a lot on this, and she talks about the importance of this multidisciplinary approach. It is important to know that hydroxyurea is teratogenic. So in my patients who are desiring fertility, both men and women, if they want to have children, we recommend that they use interferon rather than hydrea during that time period because of the teratogenicity of hydroxyurea. Therapeutic options exist while you're pregnant, including aspirin, low molecular weight heparin, and interferon. But it's important to talk about all these things before conception, so preconception. Pregnancy in low-risk patients can be managed with venesection, with aspirin, and without any particular safe targets. In higher-risk patients, you want to make sure that they taper off anagrelide or hydrea prior to the conception and then use interferon alpha during pregnancy, where there's adequate data that this is likely safe in pregnancy, although not 100%. And you want to prevent clotting. In some patients, I'll use low-dose, low molecular weight heparin and aspirin, certainly in patients who are considered high risk for pregnancy. All right, other cancers, I'll briefly go over this. There is an increased risk of other cancers. I want you just remember that. You want to make sure you're getting your pap smears, your mammograms on time. We've talked about skin cancers. Everybody needs to get good, no tobacco, good sun protection, age-specific screening, mammogram, colonoscopy and prostate exam depending on your family history, low-dose CT scans if you're a smoker. And then make sure provider collaboration is something you talk about. Again, I get back to this because I think doctors don't talk to one another very much, and I think your fact that you're here is going to help engage them in your care as well. So I'm ending with this picture of Tasmania because I took advantage of my trip down here to go hiking there, and it just blew me away. Your country is not only one of gracious people, but really unbelievable landscapes, and I feel very lucky to have been here and to be with you. So thank you very much. And of course, thanks to Ann and Ruben. And to you guys, I can't, the talks about how you've grown and what it's taken for people to organize this kind of meeting is really breathtaking. So congratulations to you.